Hello, everyone, and welcome to the TMA Ask the Expert podcast series. Today's podcast is entitled Autoimmune Encephalitis and Rare Neuroimmune Disorders. My name is Chrissy Dilger, and I will be moderating this podcast. The TMA is a nonprofit focused on support, education, and research of rare neuroimmune disorders. You can learn more about us on our website at myelitis.org. This podcast is being recorded and will be made available on the TMA website for download via iTunes. During the call, if you have any additional questions, you can send a message through the chat option available with GoToWebinar. For today's podcast, we are pleased to be joined by Dr. Michael Bradshaw and Dr. Tracy Cho. Dr. Michael Bradshaw graduated from Mayo Clinic School of Medicine in Rochester, Minnesota, and went on to complete his neurology residency at Vanderbilt University. He completed additional training in multiple sclerosis and autoimmune neurology at Brigham and Women's Hospital, Massachusetts General Hospital, Harvard Medical School. His practice and research focus on multiple sclerosis, autoimmune neurology, neurorheumatology, neuroinfectious disease, and other rare neurologic diseases. Dr. Bradshaw and Dr. Sarah Qureshi together run the only National Multiple Sclerosis Society Center for Comprehensive Care in Montana. He is an assistant professor of neurology at Rosalind Franklin University of Medicine and Science, and he practices at Billings Clinic in Billings, Montana. Dr. Tracy Cho graduated from Yale School of Medicine and completed his neurology residency at Massachusetts General Hospital, Brigham and Women's Hospital, Harvard Medical School. He obtained advanced training through a fellowship focused on autoimmune and infectious neurology. He co-directed the MGH Autoimmune and Infectious Neurology program for several years and recently joined the University of Iowa to be Director of Neuroimmunology and Vice Chair for Education. His practice and research focus on autoimmune neurology, including transverse myelitis, neurological infections, and the overlap of rheumatology and neurology. We want to thank the Autoimmune Encephalitis Alliance for collaborating with us on this podcast. So welcome and thank you both for joining us today.
Thank you.
Yeah, so first off, if we could just get an overview of what exactly autoimmune encephalitis is. Dr. Cho?
Sure. So encephalitis is a term that means inflammation of brain tissue, and it's kind of a generic term. The inflammation can be due to infection or to autoimmune processes. Sometimes the encephalitis just involves one part of the brain. Other times it involves the entire brain. So some of the encephalitis cases are associated with a specific antibody when the patient's own immune system is basically attacking the brain. And other types of encephalitis might occur or be part of a broader disease that's affecting other parts of the body besides just the brain. Within the autoimmune encephalitis category, we often distinguish between encephalitis that is related to just an aberrant immune system response versus those that are triggered by a cancer. Those triggered by a cancer are termed paraneoplastic because it's related to the neoplasm, which is another word for cancer. And again, many of these autoimmune encephalitis types can be further categorized based on what part of the brain is involved, what specific antibody is present, if there is one. In general, encephalitis comes on fairly quickly over days to weeks and occasionally can come on over months. So when a patient presents with symptoms that might be related to encephalitis, such as memory problems or confusion or psychiatric symptoms or seizures, then autoimmune encephalitis is one of the considerations, but we also have to look at whether there might be an infection or an underlying tumor that is triggering the process.
Okay, great. Thanks. That's a really good overview. So, Dr. Bradshaw, can you tell us what the diagnostic criteria are and if there are any diagnostic tests or biomarkers for this disease?
Yeah, so the diagnostic criteria, I think most importantly, like Dr. Cho was outlining, are first to determine whether the patient has clinical features that would be consistent with encephalitis or brain inflammation. When faced with a patient that looks like they have encephalitis, there are a number of other things that are non-inflammatory, in addition to the inflammatory causes that Dr. Cho outlined. So things like intoxication or systemic infection that can cause confusion, things that we call encephalopathy, which is a more broad general term. So it's important for clinicians to first distinguish between a non-inflammatory encephalopathy and an encephalitis. And that's based on clinical features, what the patient or their family members tell us as we're evaluating the patient. It's also based on a number of tests, such as neuroimaging, including brain MRI or PET scans sometimes, blood tests, and testing the fluid around the brain, which is called the cerebrospinal fluid, or CSF. So there was a paper in Lancet Neurology in 2016 by Grouse and colleagues, and a number of experts contributed to that paper, which tried to shift the emphasis when evaluating a patient with possible encephalitis to a more clinically practical approach rather than relying too heavily on these antibody tests, which are very important but are not the sole criteria. So we tend to think of, as Dr. Cho outlined, the clinical features being a rapidly progressive course. Usually it's over the course of days to weeks, but up to maybe even a few months, with clinical features, as Dr. Cho outlined, confusion, psychiatric disease, seizures, abnormal movements, things like that, or depressed mental status, accompanied by certain features such as new focal central nervous system features that we would determine based on examination, on examining the patient. Also new seizures and inflammation in the fluid around the brain, the cerebrospinal fluid, based on lumbar puncture and CSF examination. And MRI of the brain is often used and is also useful for identifying patterns of disease and for evaluating for conditions that can mimic an encephalitis, like just an underlying brain tumor can look very similar to encephalitis without the imaging. And so then we use those clinical features to elevate our suspicion, and then we try to exclude other causes as reasonably as possible. And I think the last thing I guess I would say is that EEG, which is electroencephalography, is where we put electrical leads onto the scalp, and we can monitor the electrical activity of the brain. And that's often used as well to determine if patients are having subclinical seizures, which are seizures that you can't really see when you're just looking at someone. And that's especially important when a person is unconscious. So I think that summarizes most of those points there.
Okay, great. Thank you. So the TMA, as you know, we advocate for disorders such as TM, NMO, MOG-AB disease, AFM. So how does autoimmune encephalitis potentially overlap with these conditions? And how can someone tell if they have autoimmune encephalitis versus, ADEM, NMO, MOG, etc.? Dr. Cho?
Sure, okay, I can take a step first. So transverse myelitis can occur in many different diseases, and many of those diseases also affect the brain. And so just like we use the term encephalitis for brain inflammation, myelitis is kind of a general term for spinal cord inflammation. And when they happen together, we call it encephalomyelitis. And it can go on with many more syllables depending on how many things are involved. But the diseases that can cause transverse myelitis and affect the brain include diseases that you already mentioned, like NMO and MOG. Obviously, the most common one is multiple sclerosis. The pattern of how the patients present in terms of the timing and what features they have often point in a direction of one or the other of these diseases. So most autoimmune encephalitis patients do not have transverse myelitis at the same time as their encephalitis, or it's not a very prominent part of the disease. There are certainly exceptions to that, but for the vast majority of patients who have autoimmune encephalitis, transverse myelitis is not typically a major feature of what we typically think of with antibody-mediated or paraneoplastic encephalitis. If transverse myelitis is present, it can be due rarely to the same thing that's causing the autoimmune encephalitis, or it could be that the patient, in addition to autoimmune encephalitis, also has another disease, and typically the ones that happen together with autoimmune encephalitis are NMO and MOG, although other diseases like ADEM or neurosarcoidosis can also be seen with transverse myelitis. So just to clarify some of that terminology, NMO and MOG are often grouped together as diseases that typically affect the optic nerve and the spinal cord predominantly. NMO is a little bit different in that it is due to a specific antibody, and we know the antibody being present is the cause of the symptoms. We know that NMO, because it's due to the immune system tendency to make these abnormal antibodies, it can also be present in patients who have other autoimmune diseases. That is to say that if a patient has an immune system that has a tendency to make antibodies against its own tissues, they sometimes will generate antibodies that cause different diseases. So it's not unusual that patients with NMO also have diseases like lupus or thyroiditis or other non-neurologic diseases that are due to autoimmunity. So in that sense, because autoimmune encephalitis is also an autoimmune disease, there are going to be some patients who just have a tendency to make these antibodies, and they happen to have two different diseases because their immune system is a little bit hyperactive. And I'll turn it over to Michael from there.
Yeah, I would add that along the lines of what Dr. Cho was saying, we see some overlap of autoimmune encephalitis with these, MOG antibody or the aquaporin 4 antibody, which is the diagnostic marker for NMO. And in maybe as many as 3% of cases of autoimmune encephalitis have associated MOG or NMO antibodies. That was from one study so far from 2014, found that rate of about 3%. So we do see some overlap there, which can be clinically extremely difficult to identify, and that's where part of the close neurologic monitoring during the diagnosis and treatment of an autoimmune encephalitis is so important to identify patterns of illness that might suggest an additional problem, such as if someone has NMDA receptor encephalitis, the most common cause of autoimmune encephalitis, they may also develop one of these, what we call a presumed demyelinating syndrome, or MOG or aquaporin 4 antibody, and they can develop focal neurologic deficits that evolve in a typical temporal profile that would be consistent with one of these demyelinating conditions. And so neuroimaging, again, is sometimes necessary, and to identify those, as well as the exam and ongoing neurologic monitoring. And those patients who have this overlap, that perhaps 3%, the number could be more or less depending on further studies that come out, they tend to be less likely to have an underlying malignancy, which, like Dr. Cho was talking about, suggests that perhaps that individual just has a greater predisposition to generating autoimmune antibodies. And so that rate was about 1 of 23 patients in that study versus 18 out of 50 for the non-overlap syndrome autoimmune encephalitis. And in that study, at least, most of the patients who had the overlap syndrome had a more protracted recovery and more residual deficits that tended to be mostly related to the the demyelinating or the astrocytopathy of the NMO or MOG rather than the autoimmune encephalitis itself. So, and that suggests that they may need further treatment and closer monitoring. We reported a case of that with Dr. Froman and Tanuja Chitnis in neurology, neuroimmunology, and neuroinflammation recently. That was an interesting exploration of that, and he did very well. But it was a challenging case for sure.
Great, thank you both. Those were really thorough and great answers. So you mentioned some antibodies. What are the different antibodies associated with autoimmune encephalitis? Dr. Bradshaw?
Yeah, so in addition to, we tend to think of NMO and the aquaporin 4 and MOG antibodies. That is technically autoimmune, and they can technically cause an encephalitis, but those are generally different conditions. When we talk about an autoimmune encephalitis, for the most part, we're referring to this category of encephalitis that's caused by these antibodies or associated with an antibody. And so we broadly divide these antibodies into two groups. Those antibodies that target antigens such as proteins, et cetera, that are within the nerve cell itself, or antibodies that target an antigen on the surface or in the synaptic cleft of the nerves. So that differentiation is one of the fundamental first differentiations that we make, and they're associated with slightly different clinical course, and we think the underlying pathology is different between those. So the most common cause of autoimmune encephalitis would be NMDA receptor encephalitis, which is a receptor in the synapse on the cell surface. Other more common causes of the cell surface and synaptic antibody syndromes include LGI1 encephalitis. This is a protein associated with the voltage-gated potassium channel complex. That's an ion channel that functions in nerve signaling. And then on the side of the antibodies that target intracellular antigens, there are conditions that we call, and these are all abbreviations really for their longer words, but things like ANNA1 or PCA1, and these different antibodies are all associated with different but sometimes overlapping clinical syndromes. And we usually will test for those antibodies from the cerebrospinal fluid, although some of them, like NMO antibody, which is the aquaporin 4, are better tested from the serum. But in general, for testing autoimmune encephalitis, we think the higher sensitivity and specificity is when we test it from the cerebrospinal fluid.
Okay, great. Thank you. So you already have talked about some of the testing methods used to diagnose autoimmune encephalitis, but are there any new promising testing methods that may be developing now or coming out in the future? For example, some places are using PET scans now. What do you think about that? And is there anything else on the horizon? Dr. Cho?
So addressing the question about PET scans specifically, the way that scan works is that a molecule is injected into the bloodstream, and we use different markers to see where the blood goes that contains that molecule. And the most frequently used molecule for PET scans is a type of sugar, and we basically in the lab the sugar is labeled with a radioactive substance that when you take the scan, it basically shows up and makes that tissue look different on the scan than tissue where that blood flow is not taking the marker. So in general, it shows where there's increased energy utilization or where there's decreased energy utilization. So in autoimmune encephalitis, sometimes the standard testing like MRI and spinal fluid tests and EEG and antibody testing are all normal, or we don't get a clear answer about whether the patient even has an encephalitis versus some other cause of their symptoms. So the PET scan, if it shows an abnormal area of energy utilization, that implies that there's an inflammatory process in the brain, and that can be very helpful. There are some specific patterns that can be seen, particularly for NMDA receptor encephalitis, where there's a change in the amount of energy utilization from the front of the brain to the back of the brain, and that can be very helpful, particularly if you don't have the answer from one of your other tests. So the challenge is that PET is an expensive modality, and it's not available everywhere, and the images that you get are much more subject to interpretation. That is, the abnormality is in the eye of the beholder. So it takes a lot of experience and expertise to help interpret those. So I think PET is a very helpful resource, but it has limitations. And it really is a matter of trying to use all of the testing at our disposal together, not any one test, apart from detecting the antibody itself, is often enough to make these diagnoses. But PET is a newer one that we're using, and some of our colleagues that Dr. Bradshaw and I both know at Johns Hopkins have been doing a lot of work in that area. But other emerging technologies that I'm hopeful will help us make this diagnosis more speedily and with greater precision. One of those is something called metagenomic sequencing, and this is a method by which we can take a sample, in this case spinal fluid, and look for any proteins that are there that shouldn't be there. And instead of looking for one specific thing, such as a virus, the technology now allows basically to look at every protein in there and sequence it, break it down into its parts to identify where it came from, and then uses a lot of fancy math and computer technology to go through databases and see which of those proteins are typical for humans to have and which ones shouldn't be there. And then right now, that technology is mostly being used to identify infections that we don't either have a test for or don't suspect, but it can also be applied to antibodies or other markers of autoimmune encephalitis. And I'm hopeful that that technology, which will probably become more widely available in the next 5 to 10 years, could help us not only identify things that we might not be looking for, but also to get answers more quickly, because the current testing often takes at least a week, and patients often need to be treated before those results are back. So those are my two thoughts about the PET scan and the metagenomic sequencing. A lot of that technology has been pioneered by another one of our colleagues, Michael Wilson, and others at the University of California, San Francisco.
Okay, great. Thank you. So I know we've kind of touched on the cause or causes of autoimmune encephalitis, but I was wondering if you could just explain, anything more detailed that you have to add. And we got the specific question, if you think much of it is the immune system's reaction after exposure to a virus. So, Dr. Bradshaw?
Yeah, that's a very good question. I think it's one that many people have been asking for some time, is why do people get this? In many cases, we cannot identify an underlying trigger, and so those it remains to be seen what the underlying trigger in those cases may be, whether there was some viral infection or some other environmental exposure or some combination of, like we think with most autoimmune disease, some combination of genetic factors and environmental triggers. Hopefully we will get more information over that in the coming years. The two main causes that we do identify would be an underlying cancer, as Dr. Cho mentioned before. We call that a paraneoplastic autoimmune encephalitis. So sometimes, maybe even over 50% of the time, when someone has an autoimmune encephalitis um, and an underlying cancer, the first thing that happens is the autoimmune encephalitis, and that is the body's way of trying to attack the cancer, but the immune system accidentally recognizes the brain or certain proteins or elements of the brain as it's trying to clear the cancer, and then that causes the autoimmune encephalitis. So one of the big things that we always look for when someone has an autoimmune encephalitis syndrome is an underlying malignancy. So, for example, in NMDA receptor encephalitis, the classic association is an underlying ovarian teratoma, but some other tumors, including tumors in men, have been identified. But about 50% of patients with NMDA encephalitis will have an ovarian teratoma. And a teratoma is a tumor type that produces a number of different, it produces cells and proteins that look like other tissues in your body. So there can be teeth and hair and neural tissue and muscle tissue and things like that. And if the immune system starts attacking that, especially with the neural tissue there, it can accidentally recognize parts of the brain and attack that as well. And then the other main identifiable cause, in addition to an underlying cancer, and I should add that some of these autoimmune encephalitis syndromes are more associated with cancers than others. So the specific antibody that someone has often helps us to predict what their risk of an underlying cancer is, or which kind of cancers we should be looking for. And the other main cause that we see is herpes simplex virus encephalitis, which is actually the number one cause of encephalitis worldwide. And that's typically a monophasic illness. This is the virus that causes cold sores on the lips. It can also reactivate in the brain, or perhaps a new infection can go to the brain and cause an encephalitis, which is usually a temporal lobe encephalitis. And like I say, it's usually a monophasic illness that requires pretty aggressive treatment. It has a high fatality rate if it's not treated, but fortunately with modern antiviral agents and supportive care, we are able to get a pretty good survival rate from that. But for a long time, we've seen what looks like a relapse of HSV encephalitis some weeks afterwards in some patients. But when you test their cerebrospinal fluid, they do not actually have a reactivation of the virus. And for a long time, it was suspected that that was some autoimmune encephalitis following the viral infection. And it was really in the last couple of years that we've characterized that much further. So the current sort of estimate is that probably somewhere in the range of a quarter of patients who develop HSV encephalitis will go on to develop some sort of autoimmune encephalitis afterwards. And they can have antibody markers, such as the NMDA receptor immunoglobulin, or the antibody targeting the NMDA receptor, but they often don't fit the typical clinical pattern of a more spontaneous or paraneoplastic autoimmune encephalitis, even if they have the same antibody marker. So it's important, as we're taking care of people with HSV encephalitis, that we follow them closely even after they've completed their treatment and are in that recovery phase. And I generally advocate for close neurologic follow-up within a week or two of discharge, and then every few weeks or so thereafter, and education for the family members and caregivers of the patient about things to watch out for that might suggest the development of an autoimmune encephalitis, because that's treatable with immunotherapy, just like we treat other autoimmune encephalitides with immunotherapy. And whether or not other infections, such as bacterial infections or other viral infections, may be associated with an autoimmune encephalitis, I don't know that at this point that pattern has emerged. It seems that HSV is particularly prone to producing these autoimmune encephalitic syndromes, in part because it's so inflammatory, and there's the release of neural proteins as the brain is inflamed, all of these proteins are being released, and the immune system accidentally recognizes those and then goes on to target them later. So we'll see if there's any other associations, but that's the main viral one that we know of at this point.
Great, thank you. So I was wondering if you could tell us what the symptoms of autoimmune encephalitis are, Dr. Cho?
Sure. So the symptoms really vary with the different forms of autoimmune encephalitis, and it really depends on what part of the brain is being targeted most prominently. Some common presentations include new or sudden onset of psychotic symptoms such as paranoia or hallucinations, and in particular in someone who's not had any symptoms to suggest a psychiatric illness previously. That is most commonly seen with NMDA receptor encephalitis in particular. And as you can imagine, there are many patients who have psychiatric illness, and the very first time they develop their symptoms, they're going to be new for that person. So one of the things that has happened as we have begun to recognize NMDA receptor encephalitis as a cause of psychosis is that many patients or their families or their psychiatrists have begun to question when someone presents with what they think is something like schizophrenia, whether or not that might actually be due to an autoimmune encephalitis. So as Dr. Bradshaw talked about earlier in terms of the clinical criteria, some important things to keep in mind with the psychosis symptoms that can develop is that they usually don't happen in isolation. That is, usually there's more symptoms beyond just psychosis. It also tends to happen rapidly and to progress relatively rapidly. And the other symptoms that patients can get include memory problems, general confusion or sleepiness. They can get seizures. They can get changes in their involuntary nervous system that controls their blood pressure and their breathing and their heart rate. And oftentimes it's the other symptoms besides the psychosis that helped determine whether or not we're dealing with an autoimmune encephalitis or a more typical psychiatric illness such as schizophrenia. So some patients don't have any psychosis and they present with just seizures and often memory problems because of the part of the brain involved. And so it really varies depending on the nature of the autoimmune encephalitis. One other factor that helps us determine the likelihood of autoimmune encephalitis is the age of onset, where most patients with schizophrenia typically present as teenagers or young adults. When patients present with a new psychosis later in life, or if it has any unusual features to it, like I mentioned, seizures or other movement symptoms, then we start thinking more about autoimmune encephalitis.
Okay, great. Thank you. Dr. Bradshaw, can you tell us who can get autoimmune encephalitis? Are kids or adults more likely to be affected, or are there any populations more susceptible to getting this?
Yeah, so people of all ages have been diagnosed with autoimmune encephalitis, including very young. Dr. Dalmau is a well-known researcher and neurologist involved in autoimmune encephalitis who first described NMDA receptor encephalitis, and he has commented on patients as young as 6 months old even having NMDA receptor encephalitis. And just a couple of weeks ago, we had a patient here who was in his 80s. He was about 86 who had NMDA receptor encephalitis. So the range is broad and just about anyone can get it. But probably those young adults are in general for some of these more likely to get it. So for example, with NMDA receptor encephalitis, the median age of onset is about 21 years old. But again, they can span across all ages. And some of these conditions are more prevalent in younger people, and some are more prevalent in older adults. So, for example, the more classic paraneoplastic encephalitides, which tend to be, but not exclusively, associated with intracellular antigens or intracellular targets for the antibody, those tend to be more in older adults, I think, as Dr. Cho mentioned earlier.
Great, thank you. So when thinking about treating autoimmune encephalitis, Dr. Cho, are there any acute treatments?
Yes, there are some standard treatment approaches for either suspected or proven autoimmune encephalitis. And a lot of this depends on how sick the patient is and whether you have excluded other possibilities such as an infection. But generally, once you have narrowed down the probability of the patient's condition being autoimmune encephalitis, because the process is driven by the immune system's attack on the brain cells, the initial treatments are all targeting turning the immune system down and reducing that inflammation. So the standard treatments, all for any of these conditions, typically begins with intravenous corticosteroids, such as methylprednisolone or dexamethasone, and those are sort of broad immunosuppressive medicines that are used in a lot of different conditions, but they work very quickly and help to control the inflammation. They're not very good long-term medicines because they have a lot of side effects if you stay on them for a long time. Other possible acute treatments after the intravenous corticosteroids include something called plasma exchange, where the patient's blood is taken out through a catheter, put through a machine that filters the blood and removes the antibodies and other factors that could be involved in the disease. And then the sort of filtered blood or plasma is given back into the patient so that they have the same volume in their blood, but it's a sort of fast way of basically filtering out the antibodies and other factors that might be contributing. And then another acute treatment is something called intravenous immune globulin, and that is basically a pooled supply of antibodies that are taken from thousands of different donors. So when you go to donate blood, some of that blood is given back directly as blood, but sometimes for specific donations, the blood is actually filtered out and all the antibodies are taken out. And when you do that with thousands of people, it has a big mix of antibodies, and that can be helpful to basically suppress the immune system's production of new antibodies, and can also be effective in the acute setting as you're trying to get the encephalitis under control. So there aren't any randomized clinical trials that have shown these to be the most appropriate medicines, but it is definitely the standard of care, and a lot of it is based on just experience among experts, and also, basically using the kind of treatments we use in other similar diseases where there's inflammation of the nervous system, such as multiple sclerosis or optic neuritis or transverse myelitis. And so a lot of it is the similar medicines that you would see if you presented with transverse myelitis, whether it's due to NMO or other diseases. There are some other medicines for very severe cases that can be used, but those are the first line treatments. For those cases that are associated with a tumor, and as Dr. Bradshaw mentioned, there are some patients based on age and the way they present that where we're more suspicious for a tumor, then treating the tumor is also done at the same time as these acute immune treatments. And I guess the classic example of that would be the tumor that's most commonly associated with NMDA receptor encephalitis, the teratoma, which is typically seen on the ovary. That is the source of the stimulus for the immune system. And so while you turn down the immune system with the medicines or treatments I just mentioned, removing the source of the trigger is also key in many cases. The treatment approach in that regard is evolving as we get newer and better medicines to target the immune system, particularly if there's any issues around fertility for women with the ovarian teratoma. There may be times in which we avoid the surgery, which requires you to remove the whole ovary, and instead we use other medicines to try to avoid that. So generally speaking, the acute treatments are to suppress the immune system and to try to remove the source of the proteins that's triggering the response.
Great, thank you. And we did get a question about third-line treatments with refractory cases. So are there any possibilities or medications that you are using for third-line treatments? Dr. Bradshaw?
I think, so as Dr. Cho discussed, the usual first-line sort of options, and some people will argue that some of what we consider second or third line treatments should be considered early on as well. So treatments like rituximab, which is a manufactured antibody that targets a protein on certain kinds of blood cells called B cells. Those B cells go on to become plasma cells, which produce antibodies. And so rituximab is often used in these patients to try to stop the production of the abnormal antibody. Other aggressive treatments like cyclophosphamide carry implications for, as Dr. Cho alluded to, for pregnancy in the future, fertility for women. But that's essentially a chemotherapy medication that is sometimes used. I would say that one of the really important things when someone is not appearing to respond to the usual immunotherapy and the initial investigation for an underlying cancer is unremarkable, is to make sure that we are really doing the best testing for an underlying tumor that we can, because oftentimes if you don't find the underlying cancer and treat it, you can treat someone with as much immunotherapy as you like, and you may not get their disease under control because the underlying antigenic trigger is still there, being the tumor. And so if the initial screening test, so for example, with NMDA receptor encephalitis, we often will do an initial screen for an ovarian teratoma with an ultrasound, and if that's unremarkable or has some questionable finding on it, those usually need to be followed up very carefully with additional imaging, such as MRI of the ovaries, or even a PET scan looking for any other occult cancer inside the patient's body. And if there's anything that looks suspicious, then oftentimes that requires biopsy or surgical removal. So I would say that a lot of times, or at least some of the time, when you have a patient who does not appear to be responding or seems to be getting worse despite immunotherapy, we need to make sure that we've optimized our diagnostic investigations first and foremost. And then when we think about the clinical course that we see with these patients, even with NMDA receptor encephalitis, the average hospitalization is something like 3 months. And so a patient may appear to be stable or not appear to be changing much to their loved ones, but the neurologic evaluation remains critical, and even a subtle improvement may signal that they're actually on their way to recovery. Recovery can take quite a long time for these conditions. Even the conditions that are readily reversible in the long run will take a long time to recover in the short term. Finally, for patients with an intracellular antigen, we think the underlying mechanisms of disease between these extracellular antigens and the intracellular antigens are different. The extracellular antibody syndromes like NMDA receptor encephalitis and LGI1 encephalitis, the antibody itself appears to be or is directly pathogenic and contributes to the disease process. Whereas, and there are probably other factors as well there, but in the intracellular syndromes, we think that the more predominant feature is a immune response that's mediated by T cells, which can be cytotoxic, meaning they actually kill the neurons as the encephalitis is ongoing. And so when we find a patient with an intracellular antigen, and those usually correlate more likely with underlying malignancy, oftentimes our goal is to stop the progression of the disease. We'd like to see them improve, but if there has already been sufficient structural damage to the brain, that damage may not ever heal. And so unfortunately, sometimes our hope is to halt the progression rather than to attain complete recovery. We always hope for that recovery, but often in those intracellular syndromes, often what we see is just halting progression.
Okay, thank you. So moving on to the long-term kind of effects. Dr. Cho, can you tell us what those might be and what the prognosis for someone with autoimmune encephalitis is?
So as Dr. Bradshaw mentioned, it really depends on the nature of the encephalitis. In general terms, those autoimmune encephalitis that targets the outside of the brain cells, like an MDA, generally has a good prognosis if it is diagnosed and treated relatively soon after the symptoms develop. The reason is that, as Dr. Bradshaw mentioned, those antibodies tend to alter the cell function without killing the cell. And then if you remove the antibodies, the cell that's still there now can do its normal function, and the patient's symptoms will often improve. Whereas generally speaking, those antibodies that are targeting a protein inside the cell are usually associated with those cytotoxic cells that lead to the nerve cell actually being destroyed, not just altered temporarily. And therefore, those typically paraneoplastic encephalitis syndromes often do not recover, and a lot of their outcome depends on the ability to treat the underlying cancer. Within each of those two main categories, there's a wide variation in both how severe the original illness is and how well it responds to treatment and how well the patients recover. So in NMDA receptor encephalitis specifically, I have been amazed at the ability for patients with very severe disease to recover completely. The most extreme example of that is a patient that I had who, despite aggressive treatment early on, including removal of a teratoma and rituximab, had a hospital course that lasted 3 months in the intensive care unit, basically in a coma, then 6 more months in a rehabilitation center, and she basically had to learn to eat and walk and talk. But 1 year later, she was completely normal, back to her high-level job that she had been doing previously. So that's one example of an extreme severity of illness with a full recovery. There are other forms like the limbic encephalitis that's often associated with LGI1 that Dr. Bradshaw mentioned earlier, which is frequently a disease that happens once and then gets better and doesn't happen again. However, if the patient in that illness, the typical presentation is with seizures, if the seizures go on a long time without being controlled, they can cause secondary damage to the brain, and even after the encephalitis is treated and gone, the patient might still have a tendency to have seizures and might require to be on medicines for the seizures. They might also have trouble with their memory because that same part of the brain is involved in learning and memory. So the important points are that early recognition and treatment are very important, and each individual patient has to be taken in context to determine their prognosis and their long-term outcome. And as Dr. Bradshaw mentioned, our goal is to keep finding earlier ways to diagnose these patients and better treatments. So even those that tend not to recover with the paraneoplastic syndromes, our goal is hopefully to have ways to stop the progression early on and preserve the brain tissue so that there aren't any permanent impairments. But we're a long ways off from that at the moment, and how a patient does really is dependent on the nature of their encephalitis.
Hey, thank you, Dr. Cho. So I think you might have mostly answered this, but if there's anything you want to add to how many patients need ongoing treatment for relapses or becoming chronically ill, and what are those treatments?
So, Dr. Bradshaw, do you want to take a turn here? I'm happy to answer.
Sure. Either way is fine. I guess I would just say that I agree with what Dr. Cho was saying, and relapse rates for some, vary from one encephalitis syndrome to another, and we see those, for example, in NMDA, LGI1, or a couple of others called Casper2 or AMPA encephalitis. We see a relapse rate in the range of maybe 12 to 35%, and that typically, if someone's going to relapse, it typically happens when the immunotherapy is being tapered or discontinued. And so I think probably if you asked 10 different autoimmune neurologists, they would each give you a slightly different answer on what their typical practice is. It's always tailored to an individual's course and the severity of their illness in the first place and response to treatment, et cetera. But I say that in general, I tend to favor immunotherapy maintenance for 2 years or so, particularly when there's no underlying malignancy. If there was a tumor such as the teratoma and that's been removed, patients may not need more long-term immunotherapy. And typically what we will use is rituximab, because there is some decent evidence with that. But some people will do pulse doses of IV steroids or IVIG, like Dr. Cho discussed before. And I would just say that while tapering immunotherapy, we just need to monitor our patients closely in order to determine if they're having some early relapse symptoms. But each of these autoimmune encephalitic syndromes are associated with different rates of relapse in general.
Okay, great. Thank you. So there is sometimes a fear that people with autoimmune disease have about getting vaccinations and other kinds of injections. So Dr. Cho, is it safe for people with autoimmune encephalitis to use an injectable medication after their inflammatory attack? And what about vaccines?
The short answer is yes. Vaccines are different than injectable medications in that they're designed to activate the immune system to generate a response to protect the patient from a future infection. So the way vaccines work is they are designed to generate the immune system to activate, recognize whatever the protein is that is usually either from or similar to an infection, such as the flu virus. And so it is a very common question for autoimmune diseases, whether it's encephalitis or a peripheral process like the inflammation of the nerves that occurs in Guillain-Barré syndrome. And the bottom line is that a lot of these vaccines are given, particularly the flu vaccine, because we know the risks of getting the virus, the flu virus, is very high and people die from it every year. And that is a quantifiable risk that is lowered by being vaccinated. Because so many people get vaccinated, millions of people get vaccinated, inevitably some of those people are going to also have an autoimmune neurologic disease. And so it's very tempting to look back and say, well, maybe the vaccine caused the autoimmune encephalitis. We don't have good evidence that that's the case. there are certain forms of autoimmune disease in the brain that are very clearly related to vaccination, and more commonly in children, in particular, something called acute demyelinating encephalomyelitis, or ADEM, which many of your listeners may be familiar with because it commonly causes transverse myelitis. And that has clearly been linked to vaccination, mainly in children. Even in that case, it's very rare, and the risks of not getting vaccinated, for instance, for measles or mumps, still is more dangerous than getting the vaccine. Once you've had one of these diseases, I think it's really a gray zone as to whether to get a vaccination afterwards, particularly in the short term. But in general, I recommend that my patients with autoimmune encephalitis definitely get vaccinations that are appropriate for their age and their risks. And many of these patients, as Dr. Bradshaw mentioned, end up on medicines like rituximab, which might lower your immune system's ability to fight off infections. And therefore, it's even more important to have protection if you can get the vaccination before you start your treatment. One of the issues with medicines like rituximab is that it makes vaccinations less effective because you need your immune system to respond after the vaccine in order to generate that protective effect. So that was a long-winded answer, but the short answer is that we don't have great evidence that vaccines trigger autoimmune encephalitis. It's theoretically possible, but because autoimmune encephalitis is so rare and the diseases that we're trying to prevent with vaccines are not rare and can be very dangerous, I still recommend vaccination, and I wouldn't avoid a vaccine that is appropriate for a patient out of fear of triggering the autoimmune encephalitis. In terms of other injectable medications, I think it really depends on the nature of the medicine. There's not a clear link between any particular infusion and the development of autoimmune encephalitis. And obviously, a lot of the treatments we use for autoimmune encephalitis involve infusions. So I don't think that is generally a concern, but there may be some specific medicines that might have more of a tendency to affect the immune system, particularly newer medicines that are used for certain cancers that are basically designed to rev up or activate your immune system. And some of those are certainly associated with autoimmune types of illnesses. The category of those medicines is called checkpoint inhibitors. So if someone has a history of autoimmune encephalitis, later develops an unrelated cancer for which one of the treatments is these newer medicines called checkpoint inhibitors, there's no current evidence that there's a strong risk for recurrence of autoimmune encephalitis, but that would be something, a patient that I would want to monitor more carefully and have a low threshold for testing for recurrence.
Okay, thank you. So we're getting near the end of our hour here, but I did want to ask one last question if we could get to it. So Dr. Bradshaw, we often get questions of patients who want to participate in clinical trials. Are there any expected developments?
To my knowledge, right now, there are no actively enrolling clinical trials in the United States. Dr. Cho may know otherwise, but that's my understanding at this point. It's very difficult to study this because it is a rare condition, and so what we as a scientific and medical community really need to do, an important next step going forward, is interinstitutional collaboration in order to try to generate the numbers necessary to really organize and perform an adequate clinical trial if we can. We may never really be able to do that, so we'll see. But I think there may be a clinical trial in Europe and maybe one in Korea about the acute treatments, but to my knowledge, nothing in the United States at this point. I don't know, Dr. Cho, do you know of anything in the U.S. right now?
No, that I agree completely. There's a group out of Oxford that has done a lot of research on autoimmune and paraneoplastic encephalitis that is doing a trial in the United Kingdom on NMDA receptor encephalitis using IVIG and rituximab. There was a prior proposal for a very similar trial in the United States, and it was just very difficult to get enough patients. And so Dr. Bradshaw and I are both part of a group of folks focused on rare encephalitis and other autoimmune neurologic diseases, and we are hoping to continue building a network so that we can enroll at 20 different hospitals to get enough numbers. And I think groups like the Transverse Myelitis Association and the Autoimmune Encephalitis Alliance are very helpful for raising awareness about these rare diseases and giving a voice for the patients to advocate for better funding for research, and just making other physicians aware so that they know to seek out the right testing or to seek out an expert to help make these diagnoses and get patients involved. You definitely can ask with your local physicians. There are some hospitals that do research on these diseases just to better understand them without doing a trial of a different treatment. So there is some research going on, but just as Dr. Bradshaw mentioned, we don't currently have treatment trials available, but our hope is to be able to get together as a community across the country and develop, a network where we could enroll a large total number of patients from multiple different sites, and that's the goal in terms of treatment studies for the future.
I would just add to that the American Academy of Neurology has a online community called Synapse, and there's an autoimmune neurology section there that basically anyone can go and post a question that basically anyone in that group can go and respond. So if clinicians are out there and have an unusual case that they're not sure what they should do, and they want to get some input from colleagues at multiple different institutions, that's a nice place where one could go and pose questions. And I think that's been very helpful for a number of people in getting those questions answered, and facilitates this interinstitutional collaboration that I think is so important.
Okay, great. Thank you both so much. That was very informative. Unfortunately, that is all we have time for today, but we hope to continue this conversation both with the medical experts and the Autoimmune Encephalitis Alliance in the future. So thank you both, and I hope everyone has a great day.
Thank you much for
having us.